Hello, my name is Tony Rivas, and I am the president of AACR. And I have the honor of welcoming you to the second day of the AACR virtual meeting on COVID-19 and cancer. After an exciting first day, today we have a keynote address, 4 symposium, 2 forums. This is a CME accredited activity, and information on how to get CME is available in the AACR website. Now, I have the honor of introducing the opening keynote speaker of the day, Dr. Solange. Sol is full professor and chair of medical oncology, as well as the thoracic malignancy program in the Department of Oncology at the University Hospital of Lausanne, Switzerland. Dr. Peters is the president of ESMO, the chair of the ESMO Women's for Oncology Committee, the scientific coordinator and foundation council member of the European Thoracic Oncology Platform, and the vice president of the lung group within the Swiss Group for Clinical Cancer Research. Dr. Peters is a recognized expert in lung cancer and has been at the forefront of a global effort to prospectively collect information of patients with COVID and cancer. She will present her keynote talk titled Flexibilities to Sustain Solidity, addressing new vulnerabilities in cancer at the time of COVID-19. So,
dear colleagues, it's my great pleasure to discuss with you the topic of COVID-19 and cancer. My talk will be entitled Flexibility to Sustain Solidity, Addressing New Vulnerabilities in Cancer at the Time of COVID-19. I had the pleasure to prepare these slides with my colleagues from the ESMO staff and ESMO committees, as well as my colleagues from CCC19 and TERAVOLT consortia. This is my disclosure slide. Optimizing cancer care is part of the agenda for sustainable development adopted by the United Nations member states in 2015, aiming at providing a shared blueprint for peace and prosperity globally now and in the future. You can see here under the Sustainable Development Goal number 3 and the paragraph 3.4, this aim of reducing by 1/3 premature mortality from non-communicable diseases, NCDs, through prevention and treatment by 2030. Despite the considerable progress made earlier in the century in the prevention and treatment of non-communicable diseases, the momentum of changes has dwindled since 2010. The annual decline of the risk of dying from a major non-communicable disease between the ages of 30 and 70 is progressively slowing down. There has been, as you can see on this slide, a chronic underinvestment in the prevention, early diagnosis, screening, treatment, and rehabilitation for non-communicable diseases. In 2019, health systems were unable to fully respond in the majority of countries to the healthcare needs of people living or affected by NCDs. This led, as you can see on this slide, to this pre-COVID conclusion that a substantial reduction in NCD mortality requires a strong reinforcement of all health systems to optimize delivery of NCD services. However, it was the time of the outbreak of COVID-19, with the following disruption of services for the prevention and treatment of all NCDs. The most severe the transmission phase of the COVID-19 pandemic, the more the NCD services have been disrupted at that time. People living with NCDs have become even more vulnerable, becoming severely ill or dying from COVID-19, but also being undertreated specifically for their NCDs, as you can see on this slide, with this very impressive number, for example, of the decline in taking care of cardiac emergencies, of diabetes, but also this drop in the number of diagnoses of cancer in Netherlands by 25%, showing this insufficiency in our delivery in medicine in general. At the time being, 77% of ministries of health have started to collect data on NCD-related comorbidities for COVID, fearing an excess of deaths related to non-communicable diseases at the time of COVID. 120 countries did report that NCD services are disrupted at the time of COVID. And as you can see, almost half of these countries describe that the cancer treatment services were partially or completely disrupted by this pandemic. If you try to look at the main causes reported of NCD service disruption, you can see that we really speak here about operations and management of care, with being quoted the decrease in patients' volume due to cancellation of elective care, the closure of population-level screening programs, as well as very practical issues like government or public transport lockdowns hindering access to health facilities. It means that we need to be better prepared in order to offer services in the future, whatever happens. I like this modeling of the effect of COVID-19 on cancer screening and treatment. This is assuming a moderate disruption in care that would completely resolve after 6 months. But this moderate disruption would mean suboptimal care, postponing procedures, deferring care, some kind of upstaging of the disease. And if you use this model in the US, and based on this assumption, you have to expect an excess of mortality from breast and colorectal cancer of almost 10,000 deaths. And this just gives an idea of the amplitude of everything we are doing. We, of course, will need to build back together. The execution of a forward-looking strategy is extremely important and have to include all the NCDs, including cancer. Now, immediately, we need to issue specific and practical guidance on the continuity of essential health and community services for NCDs, regardless and irrespective of what will happen with COVID, a second wave, or a continuous rate of infection worldwide. Tomorrow, we will have to address again the historic underinvestment in NCDs, and we will have to call for new international funding patterns. We have been interrogating specifically our cancer care at the time of COVID. And there is, of course, it's of course about this distressing intersection of COVID-19 and cancer. We need to be able to fully describe the picture of cancer patients being infected by SARS-CoV-2. We need to use very large registries in order to acknowledge the diversity of our cancer patients, right? And in order to be able to multivariate all of our conclusions. I'd like you to quote two very important registries, so CCC19 as well as ESMO Co-Care. CCC19 is a very large consortium, mainly working in the Americas, meaning US, Canada, and South America, mainly US today. And the ESMO Co-Care, which will be the little sister of CCC19, using part of the same questionnaire, parts of the same dictionary, and targeting Europe and Asia, having the idea of finally being able to deliver a full picture, a global picture of the COVID pandemic in cancer patients. We have been performing a third database lock of CCC19 with a total service submitted of almost 3,000 patients, as you can see. And after exclusions of some patients because they didn't meet the criteria for analysis, we were able to include in this analysis 2,749 patients in this unpublished update of CCC19 analysis. You can see on this slide the very important mortality rate now of 16% in CCC19. As you can see too, we describe a patient population which needs very often ICU with an admission rate of 16%, but extremely often the use of hospitalization and O2 oxygen requirement in up to 45% of our patients. Still starting from this 16% overall mortality in CCC19, it's quite interesting to look and compare with the specific populations of patients. So first of all, with the current global statistics of mortality of COVID, which is rather in the range of 5%, so strongly inferior to our 16%, but also to look at the potential kinds of factors which might affect mortality in selected subgroups. Like you can see here, the presence of cancer and notably of progressive cancer, the older age of more than 75 years old, the ECOG performance status of more than 2, and worse than anything, the accumulation of two factors like age and intubation or ECOG PS of 2 and intubation, rising up to 75% mortality in CCC19. Of course, still starting from this 16% overall mortality, we can also look at various cancer types, different diseases. And as you can see here, while breast cancer is probably lower in terms of mortality, ranging around 8%, there are some diseases which look like being presenting with a higher rate of mortality. And I think here about lymphoma, but as previously described, probably very importantly also lung cancer in CCC19 with 26% mortality. Of course, the increased sample size in CCC90s allows us now for a more robust adjustment to look at the factors associated with 30-day mortality. And we could adjust here for age, sex, race, ethnicity, region, smoking status, obesity, recent surgery, number of comorbid conditions, ECOG performance status, cancer status, and recent cancer therapy. And by doing that, you can see on that slide that we could update our selected factors statistically significantly associated with a higher mortality. I will quote them: older age with the risk being evaluated per decade, male sex, a new factor which came out, non-Hispanic Black versus white race, current or former smoker versus never smoker status. Interestingly, and again, a new factor, hematologic malignancy versus solid tumor, ECOG PS1 versus 0, ECOG PS2 versus 0, the presence of an active disease being stable versus a remission status, and the presence of active disease being progressive versus a remission status. Beyond these statistically significant factors, we also could describe some factors previously described in literature which did not reach statistical significance in CCC19, and notably and very interestingly, obesity, the administration of cytotoxic chemotherapy versus none, the administration of any other treatment versus none, or the history of a recent surgery. We also had the opportunity in CCC19 to look at treatment exposures our patients, and basically we focus here on COVID-19 directed treatments. You can see on the slide that a high proportion of patients did receive hydroxychloroquine, azithromycin, remdesivir, steroids, tocilizumab, as well as a list of other COVID-19 directed treatments that are listed here in the bottom of the slide. On the intersection graph on the right-hand side, you can see that most of the patients did not only receive one type of treatment, but very often more than one treatment, a combination of treatment, very probably in a sequential fashion following the course of the disease. Looking at this data, and the specific research aim here is really to improve our understanding of patterns of care for patients with cancer and COVID-19, as well as specific outcomes related to this COVID-19 treatments. This first line is showing you the significant predictors of treatment exposures. So as probably expected, you can see on this slide that comorbidities like cardiac comorbidities or renal comorbidities are strongly associated with the absence of exposure to hydroxychloroquine and remdesivir, as indicated by contraindication looking at the potential toxicities of this drug. But very interestingly here, we could show that the fact to suffer from a moderate or severe COVID infection is of course correlated with a higher chance of being exposed to anti-COVID-19 drugs. Very importantly also in this series for the first time, and we were very disappointed to see that there was a statistically significant reduced exposure, probability of exposure in the population of patients being characterized by being non-Hispanic Black people. And this might be related to the fact that remdesivir was only accessible mainly through trials in very selected academic trials. This non-Hispanic Black, I would say, reduced exposure to drug could have been compared, for example, to the ECOG performance status of 2, which also was one of the factors reducing the probability of being exposed, but that's time for very rational reasons, right? Looking at the mortality associated to this treatment exposure to anti-COVID treatment, this is a slide giving you the results. Patients receiving hydroxychloroquine plus any other therapy had a statistically significant increased risk of mortality compared to positive or negative control. Positive control is any other treatment. Negative control is not being exposed to this treatment. This held true in matched and in unmatched model. And the same was found if you had to exclude from this analysis the most severe cases of COVID-19 infection. Interestingly, hydroxychloroquine treatment alone was not associated with this increased risk of mortality. Looking at the other compound, remdesivir alone was associated with a decreased 30-day mortality in comparison with positive control, and was also numerically associated with a decreased likelihood of mortality in comparison with negative controls. Interestingly, in our data, high-dose corticosteroids plus any other therapy was associated with increased mortality in comparison with controls. Interestingly, putting all these results in perspective with previous trials, our findings strongly indicate that the role of emerging treatments do require formal prospective control trials in the future. Beyond this CCC19 data, we also were exposed to several other initiatives and surveys, and for example, dedicated survey TERAVOLT looking at thoracic malignancy, and hematology, European Hematology Association survey looking at hematological malignancy, and a very interesting survey we were performing in collaboration with Australian colleagues looking in general at cancer services at the time of COVID. And all these surveys are ongoing, but I would like to remind you the data of TERAVOLT presented at ASCO, focusing on thoracic malignancy, and basically the numbers in red showing you that the mortality due to COVID in thoracic cancer patient is extremely high in an unpredictable fashion with almost 36% mortality. The other important data in this slide is the fact that a very small number of them, a very reduced number of patients were admitted in ICU, only 8.3%, not giving any kind of value judgment, but just telling about the story of the scenario of a patient suffering from lung cancer being infected with COVID, with this high mortality and low rate of ICU admission. Looking at multivariate analysis, we're able in TERAVOLT to identify that age, the performance status, the prescription, the exposure to steroids prior to COVID infection, as well as the administration of chemotherapy as monotherapy or in combination with other anti-cancer treatments, were all statistically correlated with a higher risk of death. Interestingly, in TERAVOLT, other treatments like immunotherapy, targeted therapy, were not correlated with a higher risk of death. In TERAVOLT, during this meeting, you will be able to see the data looking at what we call rare thoracic cancer, which is very interesting, and just a glimpse into here the small cell cohort. And among the current 581 patients in TERAVOLT, we're able to identify 11% of small cell cancer. And here again, we report on an even higher mortality of 41%. And if you try to go into the granularity of specifically COVID-19 related deaths, it goes up to 36%, and still, again, showing the picture of small cell lung cancer fragile patient with COVID, a very low ICU admission of 14%. We have learned some humbling lessons. We have got through some humbling lessons from this crisis, the lessons of the missed opportunities. First of all, speaking about author responsibilities, Mera, who is one of these authors of some retracted papers, was speaking about the rush to publish during the COVID-19 crisis. And I quote his words, "I did not do enough to ensure that the data source was appropriate for this use." We also need to have a look at our standards of editing and review process, starting with the flood of COVID-19 preprints, which are not peer-reviewed, being a source of major concern today. Also, a lack of rigor has also reached the elite journals at the top of the academic pyramids, notably regarding appropriate expertise of reviewers. And here I think about sufficient data knowledge, sufficient observational study, and pharmacoepidemiology experience. And of course, thinking about what we could do, we probably have missed an opportunity for international collaborative efforts and the building of prospective series and large randomized trials. Of course, we have rushed into securing access to low evidence compassionate anti-SARS-CoV-2 drugs, and we did prioritize this elsewhere. However, we have missed the opportunity of an upfront building of high quality prospective scientific documentation, even in a one-arm trials, but does systematically document everything we do and also build dedicated trial. We could have reached a way more extensive knowledge by doing it very systematically from the very beginning. We have to rethink cancer care today altogether. And in ESMO, what we tried to do in emergency is to adapt our very famous ESMO guidelines to the COVID situation. And we did rewrite 21 adapted recommendations guideline, looking at 27 tumor types and also all the aspects of supportive and palliative care, which are all available on the website. In order to be able to adapt these guidelines or use these guidelines, depending on how much COVID is currently affecting the scenario of cancer care in every country, we did rate every recommendation according to priority. With high priority is something which cannot be negotiated because it's a cancer emergency which has to be immediately taken care of. So medium priority is something which can wait probably 6 weeks without major impact, but might impact outcome if more time is needed to perform it. And of course, the low priority is about these interventions we do, which obviously can wait until the end of the COVID pandemic. We also have tried to phrase everything together into what we call a consensus paper, which is basically aiming at identifying gray areas and burning open questions in order to provide answers to the whole cancer caregiver community. And we have been developing 28 statements, which were discussed and approved in a consensual manner by 62 top leading experts in cancers. These 22 consensual statements cover the whole field of cancer care. And I wanted to show you in this slide the diversity of coverage we have. We speak in this manuscript, which is now under review, about the implementation of telehealth and digital health being options for real-time video consultation, being about triage, intervention, and counseling. We also cover the consideration expanding the indication of GCSF in order to lower the risk of hospitalization and complication of febrile neutropenia, up to the point we discussed at the end, the last important discussion about the need to lobby for promoting clinical cancer research to continue even at a time of COVID and even if a second wave is coming to us. One of the points we might have underestimated is how much information to patients is needed. And still now, I have the feeling that we haven't fulfilled all our duties there. We have produced one of our usual and classical ESMO patient guide, trying to answer what is COVID-19 and how will it affect my cancer care. However, still we have been seeing this patient reluctance to come to consultation, meaning that we should have done a better effort in informing patients, and we have to keep it in mind for the future. Of course, we also need, by thinking about all of these parameters, to safeguard cancer care and cancer caregivers. And here it's about also other surveys that have been conducted with the collaboration of ESMO and many groups. For example, looking at women professionals and looking at resilience of cancer professionals. The ESMO Resilience Task Force has launched a survey which aims at evaluating how oncologists and other oncology professionals across the world have been affected by the challenges posed by the COVID-19 pandemic, and assessing changes also to routine practices and measuring the well-being of every professional. This was a huge success. In some days, we got 1,600 respondents, as you can see, from many countries, half were men, half were women, and lots of young oncologists. 67% of these respondents have phrased out a significant change in their professional duties since COVID-19. The main change was consisting in the implementation of remote consultation as the most important, I would say, revolution to come. But more importantly, more than 75% of them describe and I would say affirm that they have concerns for their personal safety at work at the time of COVID-19. And I think to me, it's a very important statement. Of course, we know that COVID-19 pandemic is also a risk to represent a trigger that can exacerbate all types of inequalities in our modern societies. One of these inequality, but not the only one, but one of these being the gender gap. We know that women form up to 70% of workers in the health and social sector. They are at the forefront and they are at higher risk of infection and psychological distress. Of note and of importance, the burden of care might also be higher on female professionals than men. The reason is that many women also play the role of caregivers for the family members, but also because social distancing measures and restrictions on childcare services are making, in general, work-life balance extremely difficult. Before the pandemic, we had the opportunity to describe in our committee and looking at cancer literature that women were already underrepresented in major oncology journals, particularly looking at first and last authorship, as you can see on this slide. At the time of COVID, it was nicely published already in several manuscripts that women are publishing less during the pandemic, and they are also publishing less about the pandemic. Women's posting rate on preprint servers has slowed during the coronavirus pandemic as compared to last year or as compared to the months right before the pandemic. Women account for about only 34% of all authors about COVID-19, irrespective of the position. And this number, of course, becomes worse if you look at the number of women publishing as first or as last author. We have been running, it's just ended now, a survey by the Women for Oncology Committee looking at the specific impact of the crisis on work and home life for women and men working in oncology, trying to identify and address possible gender differences among oncologists during this COVID-19 pandemic. What are the expectations of further expectation of cancer care community? So first of all, we need to keep them informed and continue to move for cancer patients, finding new ways to be at the side of oncologists. We have been transforming many meetings and courses into virtual activities, which is key to convey, inform all the community about optimal cancer care for the benefit of our patients. Very importantly, there's also a topic I'd like to cover to end my talk with you. The shortages of inexpensive essential medicines are a growing public health emergency that requires concerted and collaborative action at an international level. The situation can be particularly devastating for cancer patients, as the medicines affected by shortages often have few or no, not at all, no proven effective alternatives. Shortages negatively impact both the health of patients globally and the sustainability of the healthcare systems. That is why ESMO has made already a huge effort before and proposed a course of action with key steps to be taken in the near future. We're able to identify these causes of shortages, being delays and the lack of capacity of producing medicines, the loss of manufacturing sites, the discontinuation of products, and we are also able to phrase out, and I invite you to go through the manuscript, a number of recommendations by introducing legislations and establishing some regional strategies to prevent shortages. Why do I speak about shortages? Because there were this is a topic which was very present during the COVID pandemic, and we could find many causes for shortages during the pandemic. An increased demand for medicines, which were needed to treat specifically COVID-19 infection, stockpiling by citizen or hospital at all the European member states level as an example, travel restrictions to limit the spread of infection, but also export bans and temporary lockdowns of pharmaceutical manufacturing sites have all resulted in shortages specifically worse at the time of COVID. These did concern several products we need, for example, anesthetics, antibiotics, analgesics, sedatives, but also medicine used against COVID-19, of course, but also cancer medicine like etoposide, fentanyl, bleomycin. I would really like to stress this point because while there is a clear impact of shortages on patients' outcome, right? The causes of shortages are very complex and multifactorial. And importantly, they cannot be solved by one country alone. And here on the map, you can see that the statement we can do at the end of COVID is only a supranational solution can help mitigate the situation caused by inexpensive essential medicine shortages. And we have, again, here to get prepared. And I would say in general, the management of such a terrible crisis cannot be optimal without the building of a stronger international collaboration. And with this last word, I would like to thank you warmly for your kind attention. And I did here to thank the wonderful group of collaborators I have to build, to work, and to think together about COVID and cancer. I would like to thank you for your kind attention.
Thank you very much, Solange, for this great presentation. You not only presented new data from the CC19 consortium, which it's highly anticipated, but also the information you've gathered from being in one of the early hotspots and how this has impacted in patients with cancer. You've touched on topics that are being discussed in different sessions and forums within this conference. We have a number of excellent questions, and I don't think we're going to be able to go through all of them, but since we can know which ones were voted up, I'll start from the top. But there's been the uptake of telehealth and digital health has been one of the good outcomes of this pandemic in a short period of time, has happened. But it also shows disparities because some people do not have access. Are you concerned that telehealth is exacerbating disparities?
Well, it's a difficult question. I think we have learned some positive things from the COVID. Few of them, right? And it was not needed, of course, but few of them, and maybe probably one of them is that communicating adequately with patients is not always face-to-face and might not need to be as frequent as we were used to in the past. Probably we can mitigate or reduce a little bit the way we meet patients, or we face-to-face with patients as often as we are doing usually. Of course, it creates disparity. And the disparity is not only about the usual socioeconomic kind of classification, but also about how skilled can be patients in being able to express what they experience on a Zoom, but more probably even on the phone. So we need to evaluate it and to be very careful in trying to get to know if the quality of care we deliver when it's about telehealth is really the same as compared to the quality of care we were kind of historically given to patients coming to the hospital. And this will, like everything we do, require some prospective evaluation. So we need to be very careful before implementing something that it is worse for the patient and it provides good care. And I'm still not convinced, as you said, that this is universal and this can be used kind of really replacing the old-fashioned way to do.
Another question about healthcare disparities, especially racial disparities. So the person who asked the question noted that the use of remdesivir was lower in patients of black race in the CC19 series. Do you think it was because they were sicker and they did not qualify for the clinical trials, tend to be, or that they were being treated in centers that did not have remdesivir clinical trials? And the note is that presumably you may be able to figure this out if you don't know.
Yeah. Well, of course, we can't really know the intentions behind data. and we can't know really how the patients did travel through their disease and to the hospital. However, you have seen in this data that this disparity, and we really speak here about exposure to a drug, not the outcomes, the exposure, is only seen with remdesivir. It's not seen with hydroxychloroquine or with the other drugs, meaning that there's something special with remdesivir, which was probably not found for the other compounds. And this specificity is the fact that it was almost only given in the context of controlled clinical trials in big academic centers. So if you ask me, is it about disease severity or where the patients are addressed or where they can reach the doctor prescribing the drug, meaning high quality big hospitals, I would answer it's not about severity of the disease. It's getting access through clinical trials, through the good hospital, the right hospital to do that, right?
I'm told we have 1 minute left, so I'm going to ask, there's excellent other questions, and I'm sorry for the people who asked them that I maybe will transfer them to you, and maybe you can answer by email, but there's one general question, which is, so that people who have comorbidities and cancer may be more at risk to other infections like sepsis. Have you done any correlation between patients with cancer and sepsis and patients with cancer and COVID-19 and see, do they fare differently? Because maybe it is just a general thing of people who are sick who have an added infectious process.
I agree with you, and we try to describe for COVID maybe some parameters which just also sometimes qualify septic shock, right? A shock. So we have to be careful not to make too many assumptions about specificities of COVID. So the question is, we haven't done this analysis. However, it's still quite important to keep in mind that we have been identifying risk factors for COVID, which are usually not described for septic shock, right? Remember the story of the famous comorbidities, being cardiovascular diseases, for example, obesity. So these factors have never come out to be statistically significantly associated with any type of septic shock apart from this COVID infection story. So I think we are describing something slightly different. However, that's why it's so important, the CCC19 and the registry. When you go to cancer, suddenly you accumulate a certain number of vulnerabilities, which of course describe a specific scenario. Think about lung cancer. A lung cancer patient in third line of chemo coming to the hospital with high fever, respiratory distress. It's a scenario which, being related to COVID or being related to any other type of infectious agent, is describing a patient who is not prone to be chosen or to choose himself to go to ICU and be intubated. So when you speak about cancer, this discriminance of COVID versus the other conditions of infectious disease might potentially be a little less, I would say, different. But of course, we need to observe it. And cancer really defines a specific scenario.
Well, so this has been an outstanding start of the second day of the meeting. I want to thank you very much. There's a comment from Karen Knudsen, who's one of the program members, saying that for more discussion about telehealth and disparities, there was the forum number 2 yesterday that had an outstanding discussion about it. So we encourage anybody who missed it to go back and listen to that forum. But that's all. We want to thank you very much. I want to wish everybody a great rest of the meeting, and I will go on to the next session.
Thanks a lot. Thanks, Tony. Thanks to all of you. Bye-bye.